You can start.
Yeah. Good morning, everyone. Today I'll be presenting my free paper on onion ring sign on the spectral domain OCT in diabetic macular edema, its evolution and outcomes. So we know that hard exudates is a combination of lipid and proteinaceous materials such as the fibrinogen and the fibrin, and they happen because of vascular leakage and impaired retinal barrier. Hard exudates are not only seen in diabetic retinopathy and diabetic macular edema, but they are also seen in diseases like the polypoidal choroidal vasculopathy, Coats disease, and even aneurysmal lesions, which are including the RAM and the PEVAC diseases which are present. Cholesterol crystals are basically seen in patients with deranged lipid metabolism, and they occur as a result of the precipitation of the lipid-laden macrophages. So in AMD, cholesterol crystals are seen on the OCT as sub-RP, hyperreflective, multi-layered crystals, horizontal lines which are present, and this has been typically described in the AMD, both in the neovascular and the non-neovascular diseases, as the onion ring sign. Cholesterol crystals in DME have not been described yet, and hence we decided to do this study. So the aim of the study was to report the evolution and the outcomes of the cholesterol crystals, which are seen as hyperreflective crystalline deposits on the spectral domain OCT in patients with diabetic maculopathy or diabetic macular edema. So the methodology involved DME identifying the cases of diabetic macular edema between 2017 to 2021. It was a retrospective study, and where you evaluated on the OCT for the presence of the hyperreflective crystalline deposits. The hyperreflective crystalline deposits on the OCT, they appeared as single or multiple linear high intense hyperreflective lines on or above the RP without causing posterior shadowing. So the other data which was noted was related to the diabetes mellitus and the ocular details. And in terms of diabetes mellitus, we looked at the type and the duration and the treatment taken and any associated systemic diseases. And for the ocular details, we looked at the DR severity, the DME type, the hard exudates, and the location of the hyperreflective crystalline deposits. So we looked at 2,571 eyes of 1837 patients on the OCT for the hyperreflective crystalline deposits, and we identified only 2% of the patients had 2% of the eyes had hyperreflective crystalline deposits. Now, when you look at this table, you can see that there are some important findings which come to us, that at the time when the crystalline deposits were noted, the HbA1c levels were very high. The patients who were taking lipid-lowering drugs such as the statins were around 80%, and the logMAR visual acuity was around 20/160. Now, when you look at prior to the development of the HCD, this is very important, where we found that before the HCD actually developed, the visual acuity in these patients was much better. It was 20/76, and the median time taken for the patient to develop an hyperreflective crystalline deposit was around 27 months. Now, when you look at the visual acuity before and after, and some relevant information before and after the development, you can see there is a decrease in the visual acuity, and also the patients who are taking lipid-lowering agents were much more at the time when the HCD was developed. So this is a photograph of a patient who has shown the development of the hyperreflective crystalline deposits. I just want you all to focus on this central lesion which is present in the middle retinal layers at the foveal region, where you can see the hyperreflective crystalline deposits developing over a period of time. When you look at the visual acuity differences between eyes with and without the HCD, you can see that when the HCD was involving the fovea, the visual acuity had significantly reduced, and this reduction was always maintained. So the important takeaway points from the results were that HCDs are uncommon. They are seen in patients with deranged cholesterol metabolism. They occur over a period of 28 months. The development of the HCD is associated with poor visual acuity, and the HCD at the fovea leads to a poor visual acuity. We had some limitations. It was a retrospective study, the small sample size. We did not evaluate the response of the HCD with different treatment modalities, and we lacked OCT angiography in this case because it would have told about the visual acuity changes which we would have seen. So the cholesterol crystals are not hard exudates plaques. Mainly people say that these are hard exudates plaques, and they are not hard exudates plaques because they are appearing golden yellow in color on the clinical examination. And when you look at the OCT, you can see that at the fovea, you have these horizontal lines which do not cause shadowing. And on the right side of the OCT, you can see the typical hard exudates which show the shadowing for you. So onion ring sign at the fovea in DME indicates poor prognosis, and it is one of the poor prognosticating markers in addition to the drill and the ELM and the EZ discontinuity which we see in most cases. Thank you very much.
Octa would have helped you.
So the octa, because we wanted to talk about the octa, because the HCD we said that it is associated with poor visual acuity. So if you had done an octa, we would have also seen whether there was any macular ischemia which was seen in these patients, and whether that was responsible for the hard exudates and the crystallization or the cholesterolization of the hard exudates to happen. So whether there would have been an additive factor, and the OCT angiography would have told us that bit of information.
But you can pick up ischemia in the fluorescein also. You can pick up ischemia on the fluorescein also.
In patients where you are not doing
diabetic, I don't think you need to pick up ischemia with the octa.
So the factor responsible for visual loss, which is identified on OCT, is the presence of cystoid spaces and drill, where there is disruption, damage, either thinning or disorganization of the layers. So did you identify any damage to the structural layers of the retina which was caused by this?
So in these patients where this hyperreflective deposits were present, the OCT did not show much of structural changes. So we were solely blaming the HCD or the hypercrystalline deposits to be responsible. Even when these deposits were present away from the fovea, they were not responsible for the visual acuity loss. Only when it was affecting the fovea, involving the RP at the fovea, that is the time when they were causing the visual acuity loss.
So if there's no cystoid space, if there's no damage to any of the layers of the retina, then what is your explanation for the reduction in visual acuity?
So in the presence of HCD, the HCD is the reason why the visual acuity is less.
You mean it's just physically blocking the passage of light?
It's causing a crystallization of the RP, cholesterolization of the RP. The RP is no longer functional in those areas. There is a structural loss to the RP cells which have happened in that area. The RP is no longer functional, and the RP at the fovea is one of the primary reasons where visual acuity is determined. So,
but then if the RP was abnormal, did you find any evidence besides, because since the RP was not thinned out, as you're saying, you found no other structural signs? If there's no abnormality in the RP, how do you identify that it's not dysfunctional? Did you do anything to corroborate that? Like, for example, was a autofluorescence study done to identify the function of the RP?
So we did not do the autofluorescence. Yes, I agree that the autofluorescence would have actually told me about the health of the RP. Yeah, we did not do the autofluorescence.
Thank you.
You told the different treatment modalities had an influence in this.
So we just wanted to know whether these hyperreflective crystalline deposits, when they are present in the middle retinal layers, that is the outer plexiform, if we give a steroid or if we give a different anti-VEGF, how did it respond? Does it go away? Was it present? So that kind of analysis with respect to the different treatment modalities was not done in this.
Not related to systemic drugs.
Systemic drugs, what we found is that all these patients who developed the crystalline deposits, they were patients who were already on cholesterol lowering drugs. So they already indicated that these patients were hypercholesterolemic cases. So yeah, we did not see whether the cholesterol lowering drugs means a patient who's coming fresh to us and was not on cholesterol lowering drugs. And if we were started on cholesterol lowering drugs, what happens? We did not see that because it was a retrospective study.